How's it going, guys? The Critical Coach here. Today, real briefly, I want to touch on two concepts that you just might see on your critical care exams, all right? That's HIT, which is heparin-induced thrombocytopenia, and ITP, which is idiopathic thrombocytopenic purpura. Now, I'm not going to go too far in depth with these two conditions, but I want to touch on the key points that you want to know for your critical care exams. So first, we'll talk about HIT. First thing you want to take away is the word thrombocytopenia, and what that means is a low platelet count. Now, in the human body, the normal platelet count is between 150,000 to 400,000. And once you drop below 150, that's when you can start getting into HIT, right? Heparin is a medication that is given to patients who may have something like a PE, a pulmonary embolism, okay? And they have some type of clot somewhere in their chest, and the heparin is given to them to help prevent that clot from getting bigger and prevent other clots from forming in the body. Now, heparin is unlike TNK or TPA, where it's going to break down that clot and bust it and expel it from the chest. That's not what's going to happen. But it will prevent that clot from getting bigger and prevent other clots from forming. Now, when this platelet count does drop, it's not like these platelets are just disappearing from the body or they're being expelled some other way. What's happening is these platelets are starting to stick together. And all these platelets are starting to stick together, and that grows and starts to cause clots. And that clot travels to the body and eventually gets caught somewhere where it's not supposed to be. Okay. Once you start a heparin drip on a patient, about 5 to 10 days after you initiate it, that's usually when HIT can start to happen. Okay. Every place's protocols are different, but for most places, you want to check the patient's APTT every 6 hours once they start the heparin drip. Okay. And there's a whole protocol as far as when you can stop and when you can switch it up to every 24 hours or 12 hours. But for the most part, every 6 hours is when you want to check that APTT value. When that APTT value starts to rise above 200, that's when you know you're getting into HIT. But what's happening during HIT? The body is counteracting the reaction to the heparin. So it's kind of starting to create antibodies to fight against the heparin, and that's causing the HIT. That's where the problem lies, okay? So as I said, once the APTT rises and starts to go 200 or more, your protocol should state stop the heparin, okay? That's the first thing you should do. Before you even notify the provider, the first thing you want to do is stop that heparin. That way you can stop that whole process from happening, okay? Some providers may ask you to switch it up and give another type of anticoagulant. So you may have to give warfarin or something like that, right? Another type of anticoagulant, because you still want to prevent that clot that's in the chest from getting larger or other clots from forming. Another thing that they may ask is for you to give platelets, okay? Because that platelet count is starting to drop, they want you to replenish those platelets and bring those numbers back up, all right? Because platelets is what causes scabbing in the body and prevents clotting from happening, okay? Prevents bleeding from happening. Another thing they may ask is for you to give thrombin inhibitors. All this is to help reverse the process of the HIT and prevent further clotting from happening. Antidote. Almost all medications have some type of antidote, okay? And for heparin, the antidote that you want to keep in mind, because this may also be on the critical care exam, maybe not for this type of question, but maybe for a different type of question, is protamine sulfate. Protamine sulfate is the antidote for heparin. So as I said, I'm not going to touch too much on HIT, but I want to give you all the key points that you want to know for your critical care exam. Now we're going to talk about ITP, idiopathic thrombocytopenic purpura, okay? As I said, this is like the cousin of HIT. One of the key differences is that for HIT, when the platelet count drops below 100,000, that's when you start considering ITP is happening. And just as a fun fact, when you start dropping below 50,000 of your platelet count, that's when you're starting to enter severe thrombocytopenia, and this can actually be an increased risk for brain bleeds, all right? So what's happening with ITP? ITP is an autoimmune disorder that causes the destruction of platelets, all right? Some signs that you may also see, similar to the heparin-induced thrombocytopenia, is bleeding. What you may see is petechiae, which is like redness around the chest area, maybe around the arms, okay? Just like redness on the surface of the skin, which means that just capillaries are starting to bust and you're getting all these little red dots all over the place. You may also see some purpura as well. Treatment is different than HIT. treatment for ITP, the provider is going to order corticosteroids and may also order IV immunoglobulin. Okay, these are 2 medications to help with this process. So as I said, not going to get too in depth with these, but just want you to have the key points. All right. Further down the line, I'm going to create a more larger lesson and post it on YouTube. That way you can actually see exactly what's going on in more detail. Right. If there's any content that you guys do want to see, please let me know. Drop it in the comments, shoot me a message, whatever works for you, okay? Please, if you get a chance, subscribe, like, share, follow, and tell a friend to tell a friend, all right? You guys have a good night. God bless you.